I would say it's a mixture, so whatever the restaurant prefers. That's fine. And I was going to say, in terms of flight enhancement, we have going back. I will say that our later
Did it change? Yeah, it did. Now, if she walks away and needs to use this, she could just flip it on and...
Remember, the camera is pointed to you.
Right.
Oh, is that?
Yeah.
I will use that for Q&A.
Good morning. Good morning. I want to welcome everybody to Internal Medicine Grand Rounds, and it's a real pleasure and privilege to be able to welcome our Grand Round speaker this morning, Dr. Mandy Cohen, who serves as Secretary for the North Carolina Department of Health and Human Services. Dr. Cohen is a general internist, and in her career has really had an unbelievable impact on shaping healthcare delivery both at national and regional levels. Her medical career started, she graduated from Yale University School of Medicine, completed an MPH at the Harvard School of Public Health, and then an internal medicine residency at MGH. After finishing residency in 2008, she moved to the Department of Veterans Affairs, where she held a leadership role in the development of women's health services, and then joined an organization, Doctors for America, that played a very important role in mobilizing both public and legislative support for healthcare reform. In 2010, she moved to the Center for Medicare and Medicaid Services, where she held several roles of increasing responsibility and leadership. And while at CMS for 7 years, she had an amazing impact on shaping the implementation of some of the most profound changes in healthcare delivery in payment, including the Pioneer ACO initiative, the Comprehensive Primary Care Initiative, the Bundled Payment Program, and then one of the particular challenges she took on was the rebuilding of the federal marketplace technology platform, better known as healthcare.gov. She held the role most recently at CMS of Chief Operating Officer and Chief of Staff, and in that role played a large role in the implementation of a number of provisions of the Affordable Care Act and the implementation of new physician payment models such as MIPS and the Advanced Alternative Payment Model. Dr. Cohen moved to warmer environments in North Carolina in January 2017 to accept her current position. And in this role as Secretary of DHHS, she oversees a program that has a budget of about $20 billion and employs 16,000 people. And she's really worked aggressively to tackle some of the state's most pressing health issues, including the opioid crisis, improving the efficiency of the Medicaid program. And I think, one of the most important challenges of trying to improve the health and education of children, really, the future of the state. And lastly, in probably her most important and I'd imagine most demanding role, Dr. Cohen serves as a mother to two daughters aged 4 and 6. So, Mandy, it's a pleasure to welcome you to Wake Forest, and we look forward to your remarks.
Well, good morning, and thank you, Dr. Rosenthal, for that great introduction and very detailed introduction, but I really appreciate that. And it's really a pleasure and an honor to be here this morning, and thanks for taking a little bit of time to hear about what's going on at the state level. Given that this is Grand Rounds, I wanted to make sure to start with a patient and a patient story. Now that I'm in this role and I have the other full-time job of being a mom, I don't see patients currently, but one of the patients that I saw while I was a resident at Mass General actually has shaped the way in which I think about policy and how I do my work every day. So it was a 24-year-old woman who came into my clinic. I was a third-year resident. I was feeling pretty good about myself. I was a pretty good doctor. I just finished in the CCU, so I was like, wow, I can bring people back to life. But it was an outpatient clinic. 24-year-old woman. She's a full-time student. Had commercial health insurance. And I saw her for what we often see our patient for, some big complaints. She's feeling tired, she's losing weight, and she was losing her hair. And so, I do my normal review of systems, ask her about her family. I'm starting to think, oh, maybe she has some sort of anemia, or I even she actually had a family history of some lupus. I'm thinking, so I do a physical exam. I didn't see anything that remarkable on physical exam, but I do what I do best. I ordered a lot of lab tests, and I was a resident, so I ordered way too many lab tests, all of which came back normal. Good, okay. I remember speaking to her on the phone, and she sounded ill. Like when I saw her, she looked ill. And when I spoke to her on the phone, she still said she really didn't feel good. And she was now complaining of some belly pain as well, and she continued to lose weight. So I was like, something's aggressive is going on. I actually scanned her belly, thinking, is there anything going on? Again, I was thinking actually down like an autoimmune path at this point, thinking about Lyme disease. Anyway, I was all over the place. I see her back after 8 weeks, and I'm about to go in to see her, And I'm a resident, so I'm discussing with my preceptor ahead of time before I go into the room. I'm like, what should we do here? What are these tests? All these are negative. Where do you think I go next? And frankly, we were debating what specialist should I send her to. Are we going to go down like an infectious disease pathway? Are we going to go down endocrine? So as we're debating this, sort of, a few doors down, the nurse who had checked in the patient and brings over the vital sheet, right? And she says to us she hears us debating my patient, she goes, I really think you need to ask the patient if she has enough to eat. And it's a searing moment. Like, I still viscerally remember it. Because it was embarrassing on so many levels and jarring on so many levels. Well, one, right, you just heard I went to Yale, I was at Mass General, and I didn't ask the patient about something very, very critical to her health, right? I had no problem asking her about her menstrual periods and diarrhea, but not about what was really going on in her life. Second, I was struck by the fact that it didn't even occur to me, right? She was perfectly put together, like I said, full-time student, had commercial insurance. I'm sitting in this beautiful new women's health clinic that we had. It didn't even occur to me. And I worried about going back in 8 weeks in and saying something that would actually destroy our relationship. What if I was wrong? What if my text sort of got the wrong vibe or something from the patient, and I go, hey, do you have enough to eat? And she goes, what are you talking about, doc? And we sort of have this bond. But what was really killing me, and as I look back on that moment, was she went 8 weeks without eating because of me. You have to live with that, right? Luckily, I went in and I did my best that I could. It was a totally unstandardized question. I said, is something going on at home that we should talk about? And it was that, little bit. Clearly she had said something to my tech who checked her in that she was ready to sort of start herself to put these pieces together, right? She was having her own cognitive dissonance about what was going on in her personal life and what was going on with her body. And she started to tell me about the fact that she had just left an abusive relationship with a boyfriend. She was living out of her car. All of her money went to tuition. She was too embarrassed to call her mom because mom loved the boyfriend, and she had a lot of shame that was going on related to the abuse. Did not have a consistent place to live, and so there was trauma going on. There was food insecurity, housing insecurity, a lot of things going on that obviously we couldn't solve in that 1 minute, because also my clinic not set up to handle what she was telling me. Right, it was very easy for me to order lab tests, which are pretty expensive. Really easy for me to order CT scan. Really expensive, but I wasn't actually set up to help her with the root of what was going on, which was really driving a lot of her health issues. But luckily, once we were able to sort of connect the dots and move she was able to open up, we were able to get her luckily to the services she needed. The university was wonderful, and we were able to get her back in the right place. We had to, obviously she needed a lot of intensive work related to the trauma she experienced, but it was a forever changing moment for me as a physician as well as a policymaker. And I think about those all of the time, where we work so hard in our jobs on to react to the problems that we see in front of us, and to really sort through what's going on and differential diagnoses and what tests and what is the right information. But sometimes we miss the forest through the trees. And sometimes we're so focused on health care that we forget about health. And that has really changed the way I think about my role. And it was mentioned that, right, my department has $20 billion a year, and that feels like a lot of money. And it feels like for that amount of money, we should really be very healthy here in North Carolina, right, if I'm really buying health. But look at some of the current statistics of where we sit as a state in terms of our health. I'm sure all of us in this room are type A personalities. Like, we want to win. We want to be the best. And North Carolina is not even average, we're below average in terms of health. So like my competitiveness is kicking in on behalf of our state. I'm not happy. But then look at some of the statistics below it that are worse than just 35th, that rank us somewhere near the bottom. And sorry, and I'm standing right in front of it. So 16% of North Carolinians are uninsured that are adults. 24% of kids live in poverty. 55% of births are unintended. That's an access to care issue right there. 16% of households are food insecure. 7% of adults with asthma, that ranks us 45th. Low-income adults went without care due to cost, and nearly half of women in North Carolina have experienced some sort of intimate partner violence in their lifetime. 47th. That is shocking statistic to think about what is going on in life. And you know, if that is happening to women, think about the trauma that is experienced by their children, right? And so that is what I think about as I think about the tools that I have at my department. We run the Medicaid program. We oversee the public health department's mental health. We also run all the social services program, and that includes SNAP, or formerly known as food stamps. We run the TANF program. We run childhood subsidies. We have a lot of levers at our department that really influence health, that go way beyond health care. So it's an opportunity to think about how do we do this better and differently, and I think about how do we do and be better for my patients that I saw a number of years ago. And so we have three priorities, though there's many, many things going on in the department. Three priorities, and again, I am focused on buying health. How do I use all of the levers in my department to buy health for our state? If I'm charged with the health and well-being of our state, how do we do that? And so these are our three priorities. One, we have a big, big change going on in our Medicaid program that I'll talk through. We also have a severe opioid crisis, and if you look at the data, we are actually going the wrong way. While we're seeing a number of other states turn the corner a bit, we are not yet. And then a focus on early childhood health and education, because if you think about, again, getting all the way upstream from a lot of those impact factors, it really begins in early childhood, and that means with mom and a healthy pregnancy and a healthy first year. So we'll talk through that in a bit. I'll spend most of my time on Medicaid transformation because it's the most near-term thing that is happening, but we'll talk about all three. So just as a reminder of our Medicaid program, insures 1 in 5 people here in the state of North Carolina. So we're about a state of about 10 million. We have 2.1 million people on the Medicaid program. And when you think of a Medicaid beneficiary, your first image should absolutely be a child. We insure about 1.2 million children in the state of North Carolina. Your second image should be those with disabilities, either developmental disabilities or behavioral health disabilities. And then your third should be those folks who are in our long-term care facilities, living in nursing homes. And then we do have some women who are on our program, but very few adults. So that is our program overall. We're about a $13 billion a year budget, which means about $6.5 million of state funds, the rest federal. So we are about to very much change the way the Medicaid program works, and this started before I got here. The General Assembly was interested in moving us from a state-administered Medicaid program, so we have basically one insurance company and it's run by the state, to a managed care program, which means having private insurance companies run the Medicaid program on behalf of the state. Now, we are the largest state in the country that has not moved their program to managed care, so this is not a novel thing, frankly. We're the last, which I think is actually a good thing because we can learn a lot from what's gone on around the country. Some have done it badly. Some have done it well. Try to avoid the bad things and learn from the good. But North Carolina also has a lot of assets here. You know, I'm disappointed with where we are in terms of our ranking for health, but there's a lot of great bright spots. I'm looking at the bright spots here in North Carolina. We have fantastic health institutions. We have actually a very strong infrastructure of care coordination. Our local health departments are very strong. So lots to build upon, but we needed to make sure as we make this transition, how do you keep what's working, bring in what's new? And so we have 4 things that we're focused on as we do this, and I'll go through them. Focused on whole person care, goes back to my patient and recognizing that there's a lot going on in a patient's life, and it's not just their physical health, but it's their mental health as well as their non-medical needs. We know we have to support clinicians and beneficiaries through this transition. We're very focused on promoting access to care as we make this change, and as well as quality and value. So let me focus on whole person care. Right now in our Medicaid program, we pay for mental health and physical health very separately. We have entities called LME MCOs, or local management entities, that are sort of quasi kind of managed care-ish entities in our behavioral health space, which doesn't exist anywhere else, really. It's very unusual. But when I joined the team here in North Carolina, I was very interested in making sure that we bring together the way we pay for care in order to get the kinds of delivery of care that I think are best for patients. This goes back to where I first practiced after I finished residency, which was in the VA, where I think many of you may know that the VA spent a ton of money and time integrating physical and behavioral health, and embedding social workers, behavioral health specialists into primary care practices because they had such a high burden of mental health disease in their population. And it was that experience that very much, as well as looking at the data about looking at integrated models of care that are not only cost effective. Again, I'm trying to be good stewards of resources, buy health, right? It's cost effective and better outcomes for patients. And we've all know the patient who, comes in for, their diabetes check, and it's like right as they're going for the, I just wanted to tell you, by the way, like I'm not sleeping, or I'm having anxiety attacks every few days, right? You don't separate your mental health and your physical health. We have one insurance card. If you think about what's in your wallet right now in terms of your insurance card, that's what I wanted for our Medicaid beneficiaries. So we've worked very hard to think about how do we set up the funding streams to bring these together. But we recognize that those with different kinds of and more serious behavioral health needs need a different array of benefits. They need to have access to additional benefits. So we decided is that, okay, if you have more behavioral health needs, if your primary diagnosis are more severe on the behavioral health side, or IDD or TBI, you're going to go into something what we are calling now a tailored plan. If you're moms and kids and generally healthy, you're going to be in what we're calling a standard plan. Standard plans, the moms and kids, that's going to start first. It's going to start as soon as November of next year. So about a year from now, we'll be turning that switch. And anytime you make this big change, there's a lot of work leading up to it. So it's going to be a big year of work leading into that standard plan. Then again, on the tailored plan side, it'll lag behind a couple of years as we make sure that we work out all the operational details before we move in our more complex patients. But they will have, as I mentioned, a more expanded service array. I will still expect the standard plan to cover a wide array of mental health services. Moms who have babies get postpartum depression, so we have to cover mental health services in standard plans, but it doesn't go to sort of the to some of the more long-term supports that are needed that are in the tailored plan. So that's the whole person integration of physical and behavioral health. That's a big undertaking. It's a lot of dollars moving, a lot of moving pieces in it, but we have already put out to bid for managed care the standard plans in this way, and we have enabling legislation. And just yesterday, we got federal approval of our Medicaid waiver to move forward in this direction. So all good. Second, just to speak to you all who are thinking, well, how is Medicaid managed care potentially going to change for doctors? I think the first thing to know is as we change over, we wanted to make sure that insurance companies couldn't cut the rates or the payments to physicians. I think we can all quibble about Medicaid rates being too low, and I think that's fair, but we wanted to make sure it wasn't even going below that, so we created a rate floor of at least 100% of current Medicaid fee-for-service as we move into managed care. And I am very sensitive to the fact that all of these going from one payer paying for millions of patients to multiple payers inherently increases burden and complexity and paperwork. It just does. But there are a lot of things that we can do on our end to try to smooth that out as much as we can. So, for example, we are going to be centralizing credentialing. So you have to be enrolled in Medicaid in order to get paid by Medicaid. In this future world, you not just need to be enrolled, but you actually need to be credentialed by each and every Medicaid insurance company. And we said, wow, that's a lot of paperwork. So we are going to be centralizing that So you only have to get credentialed one time. And if you're already enrolled in the Medicaid program, you don't even have to do anything until it's sort of your time to re-up. So things like that. We also want to make sure we're doing things like standardizing quality measures across the payers. Right now we have standard quality measures because it's only one payer. If we go to multiple, they theoretically could do multiple different ways of tracking quality. Wanted to standardize that, standardize forms. Now, it doesn't mean that insurance companies can't put their own spin on utilization management, otherwise known as prior authorizations and those kinds of things. So you can't, I'm not going to be able to save everyone from that. That's a reality of managed care. But we at least are going to try to make it as easy in terms of standardized forms. The one really great part of the legislation was that it kept one formulary for all of Medicaid. So even though we'll have different insurance companies, everyone will have one formulary. So that is a big place of standardization. I think also will be very helpful for folks. And then we have rules around transparent and fair payments and making sure folks get paid on time. And if they don't, there are penalties that the insurance companies have to pay, things like that. The piece that I'm excited about as we continue to, again, bring in the best ideas from around the country is thinking about how do we really think about investing in primary care even more. I think North Carolina has done a great job thinking about care coordination and focusing on our Medicaid population's care coordination. We have a program called Carolina Access right now, where our most high-risk Medicaid beneficiaries are targeted for pretty extensive case management and care management type activities. So we wanted to keep that infrastructure. But as you go to many payers, you can imagine, think about the physician practice here at the hospital. If you go to multiple payers, then everyone has its own care coordinator flavor, right? And so you wind up having 5 care coordinators when you used to just have one. So we wanted to keep an opportunity for practices to say, you know what, I still want to do care management across my Medicaid population in a unified way. And we want to do that at the practice level. And I think care coordination happens best the closer you get to the patient, to the community, to the practice. So we created this rubric called the Advanced Medical Home, where we would actually give money, if you want to be a Tier 3 practice, we'd give money directly to the practice to take on the responsibility of that care coordination, which is often done by insurance companies. I don't think that the insurance companies are best suited to do that. I think you all, knowing your patients, working within your practice, are best suited to do that. So we set up a mechanism to have that money flow directly to practices to do that. But it's hard work. Right, you have to have the care coordinators. You need to have the data infrastructure to identify your high-risk patients. So we're thinking about ways that we at the state can support people to do that. Now, that's not for every practice. I hope all big health systems will definitely want to be a Tier 3 advanced medical home for their primary care practices. But you can imagine that's not for everyone. So we do have a Tier 1 and Tier 2 if they want to continue to partner with the insurance companies around care coordination. And we still do some additional small payments that we still have in our Carolina Access program. We do some, just a little bit of bonus money for folks. But I'm hoping that folks here, particularly at larger health systems, will take on this care coordination and become a Tier 3 advanced medical home. I have a big focus, as mentioned in my bio. A lot of my time spent at the federal government was thinking about different ways to pay for care, to drive to better health, to better outcomes. So very focused on our quality strategy and also our value strategy. And I think this is where, linking back to the earlier comments about how do we drive to health, I think we cannot keep paying piece by piece by piece if we're really going to be comprehensive and think comprehensively about our patients. And so we have a pretty aggressive goal within the Medicaid managed care program to move our insurance companies to alternative payment models by the end of the second year. That means the insurance companies and hospital systems and doctors need to arrange different types of ways to get paid than fee-for-service. You can't just stay in fee-for-service. And so I think this is important. Again, I think it helps us get to a mechanism where where we think differently than about, am I going to get paid for that CBC? Am I going to get paid for that CAT scan? And really start to think differently about patients. It's a lot of the work that, as I mentioned, we did at the federal level that we've seen a lot of positive movement forward. It is not the solution to everything. I will be the first one as people who worked on that. That is not the solution to everything, but I think it is an important piece of the puzzle. And then we recognize as we move to those alternative payment models and you want folks to focus on health, well, you need to make some investment, I think, at the state level in order to do that. So let me talk about some of the work that we're doing that is often talked about as social determinants of health. I hate that term, so we call them healthy opportunities. I think social determinants makes it feel very fixed, as if you can't, that's not a movable thing, but we know it very much is. So around healthy opportunities, we have 3 investments that we are really making at the state. The first one is sort of actually already in play. We created standardized screening questions to ask about food, transportation, housing, and interpersonal violence. We're doing the absolute opposite of what I did as a resident, which is saying, oh, is something going on at home, right? Was it horrible, right? Not standardized screening question. We've come up with 8 questions that help ask about, do you run out of food at the end of the month? Are you feeling safe at home? Standardized questions, not new. Many of us, in different practices have been working on those already. But we're going to make it required for the managed care companies as we move to managed care for them to administer that. So it's not just putting the burden on physician practices to always ask these questions. We want any door that someone walks in to be asked about this because it matters for their health. The second piece is that, okay, now we're asking hard questions like, do you run out of food at the end of the month? And you're like, what am I going to do if someone says, yes, I run out of food. I'm sitting in my practice and I'm not set up for that. So that's in part 2. This is the resource platform. So the state is partnering with a lot of philanthropic organizations to create a platform. And it's not rolled out yet, but we are partnering with a platform called Unite Us, as well as 211 and the United Way. And it is an IT platform that helps connect what's going on in our healthcare system, what's going on in our world all the time with care coordination, and what's going on in the community. And connecting to the food banks or the domestic violence shelters or the faith-based organizations in the community. Because there are resources in the community if we can connect the dots. And this isn't just a database of, hey, did you know there's a food pantry down the block? This is an actual IT platform that helps make closed-loop referrals. So if you're a doctor sitting in your practice and patient says, yes, I'm running out of food, you don't just do what I would have done in my practice, which is print out hey, there's a food bank 2 blocks from here. I hope it all works out for you. But we actually put in a referral, use our use your case management infrastructure, make that referral. Food bank gets the referral. We'll let you know, yes, Mrs. Jones showed up here or didn't, right? And you also, I think from a healthcare perspective, start to understand who are our real champions in the community that can really deliver resources and who's doing great work. And also just knowing what's going on in a more comprehensive way in your patient's life. We've seen this piloted in a number of places across the country. We will be the first to try to bring this statewide. We will be rolling it out in a number of communities. I think our first 2 communities are going to be in the Guilford County area and the Wake County. We're going to anchor them around health systems, so Cohen Health and Wake Med as first, but I hope you guys are next. So I'm excited to talk more about it, but it's a pretty exciting opportunity. Again, it doesn't solve all the problems, all right? Because there's still going to be lack of resources in the community to navigate folks to, right? But then we're going to solve one problem at a time, right? And so we'll get there. And then the third piece of this, and I'm super excited, and we just got official approval from the federal government yesterday, so it was big news, is to do some regional pilots. I've been talking about food interventions or transportation interventions or housing interventions, but in reality, we don't actually know what that means really, right? What food intervention, what housing intervention is needed for what type of patients. We know some classic examples where you see kids with severe asthma, for example. We've seen good results when instead of continuing to pay for emergency room visit after emergency room visit, which is super expensive and uncoordinated, you actually go to the kid's home, you rip up the carpet, you put down new carpet, and you give them an air filter. And it's not surprising to anyone in this room that their number of asthma exacerbations goes way down, which also means saving money because they're not in the emergency room. It means they're at school, they're learning, and mom and dad are at work, right? So productivity, better health, lower costs. So when I want to use Medicaid dollars to buy carpet, yep, I do, right? But if I just started there and there was a headline, Dr. Cohen wants to buy carpet, like they'd think I was crazy. But those are the kinds of interventions we really want to make. But then let's take that to the next step. Well, what about high-risk pregnant moms? I pay for half the births in the state through Medicaid. What do we need to do for high-risk pregnant moms? I don't know that I know what the carpet intervention for high-risk pregnant moms is. It's probably some combination of housing stability and food and some transportation so they get to visits, et cetera. But we need to test that out. So yesterday, CMS gave us approval to spend up to $650 million. That is not a small pilot. To test out and evaluate different types of these intervention strategies. So I'm pretty excited. It's over 5 years, $650 million. So, but we think that we can do some serious learning because we need to quickly. Because before we all go out and try to all create food pharmacies, which I think is great, but I want to know that that works and for whom. And for what kinds of patients. So I think this will give us a lot of new information. And I do want to say on both the screening questions and the resource platform, this is not a Medicaid-only intervention. We know from other studies, screening folks for food insecurity in the commercially insured population, you get about a 10% rate of food insecurity. My patient, right, had commercial insurance. That was not her issue, luckily. She had lots of other ones, but she had insurance. And so making sure you think about screening as well as resource connection beyond insurance status. I think clearly insurance status matters, but I think it goes beyond that. And think about your Medicare patients who are living on a low fixed income and the challenges that they have as well. So I hope you think about it beyond just Medicaid. I can't leave talking about Medicaid without talking about access to insurance coverage overall or closing the coverage gap, otherwise known as Medicaid expansion. But I don't say Medicaid expansion because it's unfortunately political here in North Carolina. But it's a really, really important piece, and I just want to spend a second on it because I think we need to move in this direction if we're actually going to truly buy health for North Carolina. We have nearly 1 million folks who are still uninsured here. The coverage gap are the folks that do not have insurance. But what we've seen is 34 other states, red and blue, have decided to take advantage of nearly all federal dollars to expand their Medicaid program to give more folks access to insurance coverage. So, you know, whether it was Vice President Mike Pence, who expanded Medicaid when he was governor of Indiana, Governor Kasich in Ohio, another Republican candidate for president who expanded Medicaid in Ohio, Michigan, Arizona, right? This is not a political issue out everywhere. And I am hoping that we are going to move to a place where we're going to have a conversation that is not just about politics. Because look, we know this is actually impacting every single one of our premiums, right? What we pay for our medical insurance is impacted by the number of people who are uninsured here in North Carolina. We see studies that show that where the uninsured rate is lower, premiums, there's a downward pressure on premiums for everybody. And we know about that. Medicine is a world of cost shifting, right? If you have to cover the cost of the uninsured, you're going to pass along those costs to those of us who have insurance, right? You can imagine the person who's uninsured who neglects their hypertension forever and comes in with a stroke. Then you're spending real money, right, as opposed to an ACE inhibitor for 10 years, right? You're spending real money to rehab someone, and often those folks cannot pay for that. They go into medical bankruptcy. Now they're not working. They are in medical bankruptcy. The hospital is out of money because they're not able to recoup those costs. Where do you think those costs go? They go to everyone else who has insurance. So we are hurting ourselves by the fact that we are not taking the federal dollars here. And so it's about $4 billion that we're leaving behind that's sitting in Washington our tax dollars up there, that we need to bring them back here. And it's not a theoretical thing anymore to be like, ooh, I think this could help us. We have many studies that have shown about what could happen when you expand Medicaid. We have 34 other states to look at. I met a resident on my way here who's studying what the impact of expanded Medicaid is on mortality. I think that's exactly right. We're seeing a number of studies that have shown morbidity improvements. I'm sure when we let the clock run, we're going to see those mortality improvements as well. But I'm not even going there. I'm just talking about pure economics. Like, this is good for our economy here in North Carolina. The way we would create the plan is actually to spend no state tax dollars. We actually have the hospitals put up some of the upfront costs because it's going to help the hospitals in the end because of the cost shifting. And the 90% of the dollars are paid by the federal government. We think we can cover 400,000 people. Of those, we estimate probably 150,000 are impacted by the opioid crisis, have a severe substance abuse, not all opioids, but have some sort of substance use disorder that we could greatly impact. And so I do think I'm hearing a lot of good dialogue as it's election season and folks are reconsidering where they sit on various issues. A lot of good movement and having a conversation about it's time. We need to look at these issues again for the state of North Carolina. So I'm very hopeful to go into the work with our General Assembly next year and make some progress on it. But they need to hear from you all. So I'd ask you to be great advocates for, frankly, yourselves, the economy, but really for your patients who are uninsured, who I'm sure you see all the time, that really need the access to care. Okay, I'm going to just touch on opioid crisis, and I don't know what time it is, but I'm going to keep going. I'm going to touch on opioid crisis in kids for a second, but then I'd love to stop and take some questions. So on opioid crisis, let me start with a stat that sometimes you don't see as much. I think we know that the number of deaths from overdose is going up in North Carolina, and actually we're seeing a division here where actually North Carolina is going the wrong direction, and we're seeing some of the other states, as I mentioned, turn the corner. And I think you see the spike here in opioid overdose ED visits. So these are folks that are coming right in your door. We had a huge spike in 2017 in opioid overdose ED visits. We're seeing it normalize a little bit more. Good news is we're seeing a dramatic decline in the number of opioid scripts written. We used to have an opioid script for every person in North Carolina. And that's really trailing off, and I think a lot of work done by the physician community to do a lot of education in this space. My concern is that, right, as folks trail off on providing those opioid scripts, there are many folks who are addicted, and then they look to the street, right, which is laced with fentanyl, and then we get our overdoses, right? And so we're in a bit of a bit of that cycle right now where we're seeing more overdoses. So, like I said, we are leveling off a little bit on the ED visits, so we feel like the last few months have actually been slightly better when you look at compared to last year. But it's not good, let me be honest, but we've been doing a lot of work to try to bring coordination together here at the state and actually learning a lot of lessons from other states. So we created an opioid action plan that we launched June of last year. And things don't change overnight for this, right? We got to this place after 25 years of pain is the fourth vital sign, right? Or fifth vital sign, sorry. Right, so that's like 25 years in the making. So we're not going to turn the ship overnight, but the coordinated work that we're doing on this opioid action plan are the kinds of things that I think can help us, right? Some of it's the emergent harm reduction kinds of things. You have to get Narcan or naloxone, and when you're discharging folks from the ED with a script for any sort of opioid, you just have to. Those kinds of things. I think we're doing all the right things, but I think we need to do more of them, and we absolutely need to get folks access to insurance coverage. The states that are really making their improvement have expanded Medicaid, and that's just because they're able to then take the dollars that they're investing in treatment and put it in some of these other infrastructure type things, the harm reductions and other types of preventative work that we can't do. Because I'll show you that we have to spend most of our dollars on getting folks into treatment, and treatment's expensive and treatment is long. These are not 30 days and done kinds of things. Addiction is a chronic disease. I don't need to tell you all that about the brain science of addiction. And so we need to treat it like a chronic disease, like we would diabetes. So we do have a coordinating infrastructure. We have been, like I said, I think a lot of great work about reducing the prescription drug oversupply, more to do. We continue to see a lot of diversion, meaning that medicine going to the black market, but we are collecting a lot of pills. Less and less. I used to, at every speech, say how many people have a couple of Percocets in their medicine cabinet, and like nearly everyone raised their hand, and it's going down, so that's good. So people are getting the message: do not keep those couple of Percocets. I don't know, I just might need them. So we're doing a lot in the community awareness side about locking your meds, but I think lock your meds is only scratching the surface. We need to do a ton more work, similar to what we did in tobacco and learn about smoking cessation. We have to do a lot more work in the prevention space. We've bought lots in naloxone and gotten it out everywhere, so I think that's been going well. But then treatment, right? We're spending millions of dollars in treatment, but treatment is expensive, particularly when we want to get folks access to buprenorphine and not methadone, which we know has better effect overall. But the federal government actually is making some good investments in opioid treatment. There's been a bunch of grant dollars. But again, grant dollars is one-time money. You can't build infrastructure with that. It's not coverage for the rest of your life, so we have work to do. But every month we update data on the opioid crisis, so take a look at all of that work. And then let me just touch on early childhood. So we are, again, similar to the opioid work, what I see is our job at the state is really to do a lot of coordinating and aligning and really knowing what we're aiming for. And so similar to what we did in opioid crisis and putting together an action plan, which I think has been very helpful to align our dollars and get us all kind of swimming in the same direction as opposed to spreading money all places. We're doing the same thing in early childhood. So the goal of this early childhood plan, and I should say my boss, Governor Cooper, this is a place of personal passion for him. He wants to make sure that we are making a huge investment in early childhood. And so on his urging, we're putting together this plan where all North Carolina children will get a healthy start, develop to their full potential in a safe, nurturing family, schools, and communities. So that's the overarching vision of what this is. And then we sort of have 3 buckets of work within it. It's a really great plan. It's going to actually be released in 2 weeks. I'm really impressed. And it has really specific goals and metrics to hold ourselves accountable. This isn't like, oh, we love children, because we love children. But we have to align our funding to some very specific goals that we think can move the needle on health, on safety, and on learning. And so I can't go into all of that, but unhealthy, you can imagine things. It's infant mortality, healthy birth weight, food insecurity, and access to preventative care. So that's sort of our space here in doctor world, in healthy. But then there's things about abuse and neglect and time to permanency and social emotional well-being and resilience. And then on reading, it's about 3rd grade reading proficiency, kindergarten readiness, and development. So there's a lot that underlies these with some very specific metrics and then strategies that map to those metrics. And I will say, it has been a helpful process for us at the department. As I mentioned, we own a lot of levers related to children and families at my department, and not just in Medicaid, but we do pay for half the births in the state. So if we can't improve infant mortality, shame on me personally, right? Because I pay for those births, and it feels like we can do a lot better than we are doing right now. So we're really working very hard to think about what are those strategies. But these are hard, really hard metrics to move for anyone who has worked on this space. But I'm excited about it. We have a run room to do it and support from my boss to make some of these needed investments. So I'm looking forward to it. So why don't I end there? Thank you for the time. I hope to share a bit about what's going on in the state and how I'm really competitive and I don't want to be below average. So help me so that we're not below average in terms of health. But just thank you for the attention. Look forward to your questions.
Well, thank you, Secretary Cohen, for a wonderful overview of the state efforts on these very challenging health care problems. So I know there must be questions in the crowd. I'll start with Dr. Rosenthal.
Mandy, thank you so much for the presentation this morning and just sort of presenting an overview of, a vision for health for North Carolina. Your case presentation sort of brought back, memories of a story that's told about Jack Geiger, who is the grandfather of the federally qualified health center initiative. And so in the early 60s, Geiger's first assignment was in this health center that was just created in a dirt-poor rural Mississippi town. And, Geiger looked at his patients, and many of them, were really didn't have enough to eat. And he began writing prescriptions for food. And then, so folks in Washington, heard about, well, geez, what's this guy, Geiger doing? And his response was, well, the last time that I checked my textbooks, the treatment of choice for starvation, is food. And I think, your talk highlights, the multiple factors that, can impact health. Actually, question, I have is, you highlighted that a lot of these issues that affect Medicaid patients are also prevalent, in other populations. I think one of the challenges for health systems is sort of our fragmented payer system, and sort of trying to live in multiple different worlds with regard to, incentives. I was wondering sort of some of the work that you may be doing around trying to align a vision for health with other, healthcare payers, and, Patrick Conway at Blue Cross in particular.
Well, thanks for the question, and I was thinking about, it's sad that we haven't learned the lessons from our health system, from our federally qualified health centers sooner. Right, I'm not talking about rocket science, and I truly don't think that I am the first one to talk about these things, but I think that the changes that are happening in the payment system that I talked about are finally getting to a place where all of this is coming together, and that's where your alignment question comes in. So Patrick Conway and I shared a wall for a number of years up in Washington, D.C., and we played different kinds of roles, but worked on very similar issues. And it's fun to have him as a colleague here, and he has some pretty aggressive goals for what he wants to do in the commercial space, which I think we are very much in alignment on that. We have, slightly different populations, but a lot of alignment. And look, he and I did a lot of work in the Medicare space already to change the way in which we want to pay, so we're learning lessons from there, tailoring it to the commercial or the Medicaid space. So I think you're going to see, I think North Carolina is set up in a very unique way to potentially leap over, like I know we're not doing so great now, but to leap over where some other states are because of that emerging alignment. And I also think there's a lot of alignment among the hospital systems as well. Now, they're competitors, but they're also, I think, all recognizing sort of where the movement is in terms of payment, and thinking more broadly about filling hospital beds, but really thinking about community health overall. I want to accelerate that even further. But I do think there's a lot of alignment, whether it's alignment on quality metrics. A great example is on opioid crisis. We had a payer council where, between us and Blue Cross, we cover about 80% of the state. And then you add in Medicare to that, and the VA, it's our entire state. So it's actually a small group of folks that can actually get together and really do something special. And so on the opioid side, I'm really excited that we were able to put together sort of principles and policies for us all to align to in the opioid space. That's not everything, but it's a really good start. If you look at our quality measures, we did a lot of work to do some alignment on the quality measure space as well. And I think as we sort of get into this world of alternative payment space, you're going to, I think, see that alignment even further. But that means a lot of change is going to happen with how we see hospital systems respond to that. So we have a lot of work to do, but it's exciting. It's exciting. Yes. Yep.
Thank you, Mandy. It's a wonderful presentation and wonderful plans, and I love where the state's going. And of course, there's always this thing about omelet and break a few eggs. But anyway, here's the question. On the sort of adult side, I was in Tennessee studying TennCare some years ago, but anyway, they tried to move somewhat behavioral health and healthcare together, And what happened was the provider infrastructure that existed, didn't do at all well with behavioral health. It appears to me you're trying to bring the two together, but I'm very concerned that the infrastructure in primary care for behavioral health, when we talk about adults or kids, is insufficient to handle what you're doing. So your response. Thank you.
I 100% agree. I think behavioral health, not just here in North Carolina, but across the country, is dramatically underfunded. I think not to be back to my one-trick pony, but like Medicaid expansion absolutely matters for that population. But what I would say is North Carolina has a bit of a leg up to where I see Tennessee was, and they've learned a lot of lessons, and we have spent a lot of time with the team at Tennessee to make sure that we can learn more lessons, as well as the team in Arizona who has been sort of working on in this space as well. What we have actually, like I said, we have this quasi-managed care-ish sort of thing. It's very technical in our behavioral health space already. So there was actually a lot of trauma that folks went through to do that work, which I think it's not perfect, but I think sets us up better to do this integration and to have managed care be successful overall. But we are definitely very concerned about it. Part of what we just got approval for yesterday in our waiver is to make a greater investment in what we're calling the behavioral health home or more care. I think my observation is missing is that, they're getting better at paying for services and getting people into services, but the coordination is not there. And that takes money, and it takes infrastructure investment, and so we're trying to commit to that as part of it. But I also think I need Patrick Conway to also invest in primary care behavioral health, and I think, it's sort of like an alignment down the road.
All right, a couple more questions here.
Thank you. That was a really great talk, and I really applaud some of the efforts, especially things like resource platform. I think that's going to be useful. We have 60% of our catchment area that is lower socioeconomic, rural. When those folks get catastrophic illness, they come here. And one of the things that is struck me since I've been here is that those are largely working poor, underinsured. How do you see the move to managed Medicare lowering the bar for entry? Because I think that is one of the issues that I've seen a lot since I've been here. Being able to have access to Medicaid, because one catastrophic illness doesn't do it, right? They have 6 months of employment that precedes that. There is a perceived income when, in fact, because we have employer-based insurance, that goes away.
Got it, as soon as they get ill. So, I think it's, if you step back and be like, how would I do this differently if we didn't have the current system that we have, right, is that you'd be working on all of the preventative care and getting folks the right screening and all that all along, so nothing, we're always going to have the catastrophic kinds of things because that's just reality of genetics and accidents and law, but we could do a lot better than we do, right? Think about my example of the guy with the hypertension who ignores it forever and then comes in with a stroke. I think that there are ways that we could, if folks had access to care through their lifetime with the opportunity to have access to primary care in particular, I think we'd be in a very different scenario in terms of the kinds of dramatic spikes in costs for individuals over their lifetime. And, and the fact that we have created insurance linked to your job is very unfortunate in some ways because when you are most sick is when it's hard to keep your job and keep that insurance. And the folks who don't understand what the Affordable Care Act is trying to do have really never been sick or have had family members who have been that sick and had to sort of navigate our very complex world. And so it's disturbing when I hear some of them whittling away things like the protections for pre-existing conditions or the lifetime caps or the annual limits, right? Those you can't understand that until you've walked in our shoes, watched our patients, or had someone in your family have that kind of unfortunate, out of the blue illness. And so, that's why we're trying to get to a place where everyone has has insurance coverage, and I don't mean to keep going back to that, but we have to get to that place. Doesn't mean that we're doing all the things right within our system. I think we have to think differently about value, and we have to think about paying differently. I think we have to do all of those things at the same time, but it starts with that fundamental access piece.
All right, and the final question from Dr. Lickstein.
It was more of a comment than a question. So your presentation is, in a sense, perfectly timed to reemphasize that every patient we see, the clinic and the hospital, it's really embedded in a larger system that extends to all the economics and how we get our communities, our society as a whole. So physicians are one of the lowest voting groups for professions, and the North Carolina Medical